Good afternoon and welcome back. We hope you had an excellent lunch and we're looking forward to you joining us for what we think will be a truly remarkable exploration of how this pandemic has affected all aspects of head and neck practice, care, and academics. And so we'll now transition to our first panel of the afternoon, which will be led by Mark Zafereo. Mark is the section chief of head and neck endocrine surgery and associate professor at the MD Anderson. He also serves as the chair of the Global Outreach Service of the American Head and Neck Society. And he and his panel will look at a topic that is truly important. As if global medicine was not challenging enough, they're going to look at the enhanced challenges of global medicine during and after COVID. Mark, thank you.
Thanks so much, Dan. We are so excited to be here. I'm honored to be here with such an esteemed panel at the AHNS at COSM. So we're going to be discussing enhanced challenges of global medicine during and after COVID. With that, we will get started here. I'll introduce our panel. So we have Mark Shrime, who is very well renowned in this field. He is at the Institute of Global Surgery in Ireland at the Royal College of Surgeons there. He also has a lecturer appointment at Harvard. We have Melonie Nance, who is the Vice Chair of Education at the University of Pittsburgh. Johan Fagan, Chair and Professor at the University of Cape Town in South Africa. We have Anna Konney, who is at Konney Teaching Hospital, where she is the head of the otolaryngology head and neck surgery department there in Kumasi, Ghana, and myself from MD Anderson. So without further ado, so just for disclosures, Dr. Shrime receives funding from the Iris O'Brien Foundation board, and he's also on the board for Faro's Global Health Advisors. Otherwise, we have no disclosures. So just very briefly, three sort of aims today. We're going to talk about head and neck surgery practice changes, challenges, and opportunities in this COVID-19 era, some challenges and opportunities in head and neck surgery training and education, as well as the evolving role of global meetings and global head and neck surgery societies. So I thought we'd just start very briefly here by saying where we are, in April 7th, 2021. And I downloaded this today from none other than Google. So this data comes from Wikipedia and the New York Times and some other sources. Worldwide, where we are with COVID is we've seen a worldwide peak, and then we had a drop shortly after the new year, and now we're rising again back up to the beginning of April. Whereas you see in the United States, this is now, there were multiple peaks. There was the first peak early on about May, June, then another peak around July, and then the peak right after the holidays. And now we're down at a much lower number. And you contrast that with what we see in some other countries. So Brazil, for instance, where you see they're now at their highest level of the pandemic in terms of new cases. In India, too, where they had a peak earlier in the year and then a drop, and then now they're at their second peak, and again approaching the highest number of new cases. So you see a pretty large disparity in terms of where we are with this pandemic, and certainly that plays into this discussion. As we emerged, as we initially set out on this pandemic back in April, May, June, there were several institutions that published guidelines and recommendations for head and neck surgical oncology practices and specific subspecialties therein, triaging patients and patient care recommendations during COVID-19 pandemic. And so these are some from MD Anderson and then Toronto and Wuhan. And this happened all over the world, and even large consortiums of experts. And Dr. Fagan, who's on the panel, is on this expert panel who gave recommendations across the globe in terms of acute severe resource constraint and how we manage these issues during COVID. So I wanted to start by just saying, talking to our panelists about some of the changes, challenges, and opportunities in the COVID-19 era. And again, recognizing that we're at various stages of this. Some may be starting to emerge from the pandemic, while others are right in the midst of the pandemic. But which of these practice changes and recommendations that you have witnessed in your own practice will stick? Which are temporary and which will be permanent? So I thought we could start by asking Dr. Nance. So if you could just tell us where you are currently with your head and neck surgery practice there in Pittsburgh, and how you're emerging from the pandemic, and what practices in terms of patient care now specifically that you expect will stick.
Hi, thanks, Mark, for having me, and I'm honored to be on the panel with this group of scholars and experts. So I'm in Pittsburgh at University of Pittsburgh, and my clinical practice is at the VA hospital, which is a government hospital. And I think telehealth is the thing that's going to stick. Everybody's been was pushing for it. The VA was really hoping to move in that direction. And I think moving in that direction a little bit ahead of maybe some of the other university and private hospitals due to the lack of constraints relative to billing. But certainly this has kicked everyone into gear in terms of using telehealth and video visits and video healthcare. And that's going to stick. I think, hopefully we are working to figure out what's the best way to do it. I think in otolaryngology, obviously we can't transition to 100% telehealth because of what we do, we're surgeons, and our work is hands-on. But I think that it's just catapulted everything in that direction. And, there are also opportunities of thinking about even doing telesurgery. And some of that is coming into the fore, especially with the robotic surgery as part of, a basic part of what we do, that is moving in that direction as well.
Those are great comments, Melonie. So Dr. Shrime, so let's hear from Ireland. So how are you guys doing in terms of your patient care practices? Are you starting to emerge from the pandemic there, and in terms of how you're treating your patients? Are you still in the midst of it? And what types of patient care practices do you think will become your new normal?
I very much agree with what Melonie has said. I think she pretty much covered it. I think what the pandemic has done for us is it's forced us to do the thing that we kind of thought we could do anyway, but then there were all sorts of barriers of payment and insurance and all these sorts of things. And the pandemic, all of a sudden, all those barriers went away because our patients still needed to be seen, and all of a sudden we could do it. I think there is a hunger from both the physician side and the patient side to continue that, to keep that going. Ireland here is emerging from the pandemic. We came off of a fairly big spike right after the holidays. Same with the US. Fairly big spike. The numbers have come back down, but just like in the US, they haven't come down to where they were before. They've kind of come down to just under the second wave. So patients still need to be taken care of, and surgical waiting lists really bumped up during the initial phases of the pandemic, and so now the challenge is to get some of those waiting lists back down.
Yeah, no, that's an excellent point. I was gonna bring that up in terms of in triaging patients in these surgical waiting lists. What have we learned? And any of the panelists can comment on this. If not, I'll call on someone. What have we learned in terms of our ability to triage patients, sort of from this pandemic, and will that stick? Are there certain tumors that are more indolent that we can watch, or maybe that don't even need treatment right away? Are there certain tumors where it's absolute disaster to have any type of treatment delay whatsoever? What types of lessons, if anybody could share, that we've learned in that regard? Johan?
Yes, in terms of triaging, we've actually had a broader discussion. In our setting, we've never been able to treat everyone that deserves care. We have long waiting lists for prostate surgery. So benign prostate surgery, so cataract surgery, so joint replacement, as well as cancers. And it's really focused us on rethinking how we priority set in a resource constrained setting. And so we just started that conversation, and we have a bioethicist who's also got involved. And so most certainly it's going to stimulate that kind of discussion going forwards.
Anna, what about in Ghana? You guys still have the long waiting list of patients there, and how are you triaging patients for surgery?
Well, thanks, Mark, for asking. In Ghana, so far from last year, we had about 90,000 cases recorded with COVID, and only we have 752 deaths so far. So the mortality and then overall involvement, not that much. I don't know whether it's contributing not to screen much, though we screen the patient and we have availability of PCR screening for the COVID. Yet, okay, let's come to our practical session. What is in our department? What has changed in the very COVID time between March and August? I can say last year the number of cases were dropped to obvious reasons, and from last year, August till now, the number of cases that we are taking on board, so the theater for elective and emergency cases have increased. Though we screen patients before surgery for COVID tests, especially those we think that they need urgent attention, and head and neck cancer surgery are becoming more prioritized over, let's say, cold cases like adenoids and the other things, the middle ear infection. So so the practice actually, we are picking up from the last year compared to the last year, 6 months until now. We are coming back to, I can say, to normal, and is improving.
Thank you for those comments, Anna. That's very insightful. Melonie, at Pittsburgh, have you guys changed your follow-up regimen in terms of patients who are maybe in a survivorship mode or survivorship clinic? In terms of typically we'll monitor patients for the first 3 or 4 months in the first year, and then sort of stagger it out from there. But have we learned anything about maybe about the ways that we need to follow patients from this pandemic? I mean, certainly during the pandemic, many of these patients haven't been able to follow up as they normally would. And has that changed our perspective in terms of what's actually necessary and some of our resource utilization in that regard?
Yes, I mean, I think, this is going to be a theme throughout, but I think we've learned, what we can do, in a pandemic and an emergency. Some of our patients at the very beginning, when clinic was almost completely closed, we were doing cancer surveillance with a visit over the phone. And with a larynx cancer, you're not going to really surveil their cancer over a telephone visit, but we were just calling, how are you doing? How's your voice? How's your swallowing? Now that's not optimal, but that's what we had to do at that time. And then when we weren't sure, who should we scope, who was at high risk, we only wanted to do aerosolizing procedures for high risk patients at the beginning. So if you were coming in, you're doing fine, maybe we didn't scope at the 6-month visit, and we would wait till the 1-year visit. So I think out of desperation, we had to decrease our frequency of surveillance. I think everybody who's ever worked at a VA hospital knows that the patients come in very frequently for follow-ups, and it's sometimes just a function of the fact that they're in the building and they want to stop by. So we really had to decide what visits are necessary and what visits are not. And I think we've decreased frequency of follow-ups, especially one patient population that's perfect for it is HPV positive patients who have done well and had a good response. So we spaced some of those patients out a little bit. And what you can do in the middle is at least a telephone check-in visit to see if they have any symptoms or something, you know, rather than doing a scope every 3 months, maybe space it out to every 6 months with a telephone visit in the middle.
I think those are very insightful comments, Melonie. I do think that is something else that may stick is some of these follow-up regimens in terms of the frequency of imaging, the frequency of scope. I mean, we all know that that many times, if not the vast majority of times, that patients with head and neck cancers, other than distant disease, do have recurrences. It's often their symptoms are often you know, what we first discover anyway. So I think that's a fascinating aspect of this pandemic that we may be able to learn from in terms of maybe decreasing some of our follow-up regimens and maybe some better resource utilization. I wanted to go on another quick topic, delays in care. So certainly there have been several studies. These are just a smattering of the studies that have been published on increased patient morbidity, mortality in terms of delays in head and neck cancer care. This paper over here to the right was just published a few weeks ago by a large international group of head and neck surgeons, led from the group from Brazil. So have we seen, Mark Shrime, in Europe and Ireland, have you seen significant morbidity, mortality from these delays in patient care?
Yeah, you know, I think this actually ties into what Melonie was just saying about follow-ups. The jury's still out. I think obviously these papers have come out, but I think there's concern, and appropriate concern, that there will be, as Manali's paper says, a tumor pandemic after the COVID-19 pandemic. You know, the jury I think is still out on how significant that's going to be, and also, you know, as we go back to the discussion of follow-up protocols. It seems to all of us, you know, on this panel that perhaps decreasing the intensity of our follow-up may actually be perfectly appropriate. And I think that's the inclination, although I would be honestly curious to see what the data show in a year or two. Are we seeing later presentations? Are we seeing later presentations of recurrences? Is what you said correct, that it really is just sort of symptoms that primarily drive people back to see us? Not really answering your question, because I think it's still a little bit too early to answer that question.
Oh, those are great, great comments, Mark. Anna, in Ghana, do you think that just because of the fear of the pandemic, I mean, you mentioned some of the statistics there in Ghana, but do you think that there's going to be a sort of a head and neck tumor pandemic after the COVID-19 pandemic? Are you seeing any of that, or you expect to see that?
Well, obviously, I predict yes. Now, with the even economy has dropped down, everything, so the patient have difficulty in everything, because they pay out of their pocket for the head and neck cancer services, for surgery, for chemo, radiation, and even transportation for some of them are challenged. So I expect more cases will come in advanced stages in head and neck cancers. Not only the head and neck cancer, I'm sure all other cancers will be equally affected. So even now, from previous time that the cancer the pandemic was so severe, some patients were postponed for due to obvious reasons, and then the cancer has progressed from initial stages to advanced stages. So as it is now, I think we are greatly affected by COVID in terms of advancement of cases in staging.
Great comments, Dr. Konney. Dr. Chandrasekhar, who is a member of the audience, asked Dr. Nance, do you think that the COVID will result in the protocols being reduced for in-person visits with televisits in between? And you sort of alluded to both of those ideas, Melonie, in your comments.
Yes, I think we're definitely doing that already. I do think, as Dr. Shrime mentioned, though, it'd be nice to study it and do it, scientifically, and make sure that we're not, seeing these recurrences later. But out of necessity, still, I think that's where we are. Our clinic is still not to full capacity because of the amount of time we have between turnover with scopes and everything. So we're still being careful about who can come in. And so we're using telehealth as a bridge for those patients.
So you're still doing most of your follow-up visits by telehealth?
Well, I wouldn't say most, but I'm saying probably, we're definitely just interspersing telephone visits.
Exactly. Yeah, great. Is there a silver lining in all of this? I mean, can we learn anything about, we talked about the potential silver lining of the, maybe reducing the frequency and duration of high resource follow-up regimens. Are there indolent cancers? I know in the endocrine realm, this is something that we talk about often, about these sort of, indolent thyroid cancers, small thyroid cancers. And even thyroid cancers that are not, micropapillary cancers, we've learned that a lot of those are very indolent and can be sort of watched indefinitely. So have we learned anything about these types of cancers or other cancers, or any novel treatment approaches that we think, may become the new normal now? I mean, Johan, any thoughts on that?
But I'm just concerned that lots of ad hoc decisions might become a standard practice without good scientific information. So I think it's very important that going forward, that if there are any changes in practices, that we should capture this data and analyze it, and we should publish. Because really, I think the quality of our care of follow-up patients has declined. We don't examine our patients as well. If a patient comes to see us and they haven't had a COVID test, we won't put a scope up their nose and look down their throats. And so I think we have to be very cautious that what we're doing now doesn't become standard practice without good scientific evidence.
No, those are very sobering comments and very much appreciated, Dr. Fagan. Dr. Fagan, you practice in a very high volume and lower resource region where some of these issues that we face, that we may not face as much in a more developed world, this pressure for rationing of patient care, lack of COVID-specific resources, increased health risk to the head and neck surgeon. So we wanted to give you an opportunity to, in the next few minutes, just to talk about your experience with that, and then hopefully we'll generate some discussion here. You're muted, Johan.
Right. Well, firstly, thank you very much for giving me this opportunity to present an African perspective. We've had two major COVID waves in Africa, one in July last year and peaked in January 2021, and Kenya at the moment is in its third wave. And you'll notice here that the number of confirmed COVID cases in Africa, which is the brown line, is a fraction of what you've seen in North America and in Europe. Sorry? But this is really an underrepresentation, because you'll see here that the excess natural deaths exceed the reported COVID deaths in South Africa quite substantially. The impact of COVID has been quite substantial. We've seen economic hardship due to lockdowns, due to the impact of curbs on travel, affecting tourism and business. There's been virtually no money for governments to provide bailouts and support as you've had in the Northern Hemisphere. It's impacting on education, both in the short and the long term, and in healthcare, of course, COVID and non-COVID. The non-COVID care has really been severely impacted. In the short term, it's been caused by staff redeployment or staff illness, beds being reallocated to COVID services, and clinics and surgery being curtailed. In the long term, the economic impacts, there's impact of immunizations being interrupted, HIV programs being curtailed, and then from the TB perspective, the WHO reported that 12 months of COVID has reversed 12 years of global progress against TB. And this is well illustrated by these graphs where you see how the number of TB cases being diagnosed has halved in South Africa. So we're sitting on a powder keg. In terms of surgical cases during COVID, you'll see that our ENT lists have been cut by 60% for the past year, and that's had a substantial impact on our services. Impact on accessing care. We just analyzed our data, and our laryngectomy patients that require emergency tracheostomy in the pre-COVID era, about 45% of patients required emergency tracheostomy, and during COVID it's climbed to 55%. So patients are having problems accessing care. Impact on training has been substantial. We only operate for sepsis, trauma, and cancer. There's been no elective surgery happening at all, and we've had to extend our residency contracts. Some comments from other African countries that they've reduced clinics from 100 to 20 cases, that aerosol generating procedures have been stopped, including scopes in Nigeria. Operable cancers are being treated with radiotherapy, and training has been extended by 6 months in Ghana. Specialist board examinations have also been impacted. The West African College of Surgeons, which includes Ghana, has deferred its exams. The College of Medicine of South Africa, that runs biannual written and clinical face-to-face exams for 28 medical and surgical specialties, has pushed through. And during the COVID pandemic, we managed to examine 1,600 candidates between June and November 2020. But we had to modify our exam format, moving to online single best answer and short written answers, and also remote structured oral exams presented by Zoom in 8 centers in the country, so that examiners and candidates do not have to travel. A bright side of the COVID pandemic has been the establishment of the African Head and Neck Society Virtual Tumor Board. It's now a monthly Zoom meeting where we present interesting clinical cases. We had our first meeting in July 2020. Our second meeting was in August of last year, and that was a joint meeting with the American Academy of Otolaryngology. And we attract up to 150 attendees from Africa and from beyond. So it's really become a very rich way of information sharing. But the dark side of COVID has been COVID nationalism and self-interest. The USA and UK have both changed their visa requirements and so that they can actively recruit healthcare workers from lower and middle income countries. We've seen vaccine nationalism and vaccine profiteering, which has really made it very difficult for poorer countries to access vaccines. And because of this, you'll note that in March 2021, only 7 million of 1.4 billion Africans have been vaccinated. And in most countries, there's been no vaccines provided at all to date. And as a consequence of this, it's predicted that most of Africa will only achieve widespread vaccination coverage early in 2023, so going forwards. And I'd like to close just with some comments from Dr. Tedros, who is also a fellow African and the Director General of the World Health Organization. And he stated that, as we know, the virus does not respect borders, and that no one is safe until everyone is safe, and that the world is on the brink of a catastrophic moral failure in terms of how we've allocated our vaccines. Mark, thank you very much for this opportunity.
Thanks so much, Johan, for that very sobering picture of sort of the ground view in on the African continent. What is the way forward here? I mean, it's a again very sobering picture how the African continent has been affected and continues to be affected. What is the way forward for us as head and neck surgeons at this time?
Well, as I said earlier, I think we have to look at priority setting, and not just with cancer, but cancer relative to other diseases and surgical conditions, and that's a real challenge. But it's also a good opportunity to examine how we actually do things.
Mark, from a global thought leader perspective, your comments on this, on some of the disparities between the COVID response and effects between the higher and lower resource settings.
Yeah, thank you, Mark. Johan, that was a spectacular presentation. You hit on all of the points here. I think the last point that you ended with, vaccine nationalism, vaccine protectionism, it's galling to see, but it's also unfortunately not surprising to see. This is something that, the inequitable distribution of resources, both human and capital resources, has plagued public health from the get-go. I think a silver linings, such as it is, of the COVID pandemic is that these conversations are now being had much more publicly, much more broadly. The fact that, even from the ethical conversations within a hospital, where, those of us in high-income countries almost kind of assume that rationing doesn't happen, now are having to deal with the idea that, care is not unlimited. So from within the hospital level all the way to this global level, Mark, what is the way forward for this? I think, we need to have a voice and should be speaking. Johan's done an amazing job writing about this, but Johan shouldn't be the lone voice talking about this. We need to be discussing the fact that we in the global north are benefiting from structures that, whether or not we see it explicitly, are hurting our fellow physicians and our fellow patients, on the other side of this structure. Some of this vaccine nationalism, unfortunately, is sort of enshrined in laws, which makes it feel like, well, then there's nothing we can do to change it. But that's exactly not right. And this is exactly the place where we can speak into this and say, look, this is not right. This is not fair. This is not just. We would never wish this on ourselves. Why do we think we can wish it on other people? I could preach a sermon on this, but I'm gonna turn it back over to you.
Oh, thank you, Mark. Those are very, very insightful comments. What are some of the, just to ask you a follow-up question, other than the vaccine nationalism and the disparity there, what are some of the other global north, global south issues, and maybe Johan can comment on this as well, that have been exacerbated by this pandemic? And I think you alluded to a few of these issues, Johan, in your talk, but Mark, have you and other sort of global thought leaders in this realm, I'm sure this has been a topic of discussion.
Johan, do you want to take that first? Or do you want me to take that? You're muted.
Unmute, Johan.
But you can take that, Mark. I'll leave it up to you.
Oh, great. I was hoping you would take it. No, so I think the migration of physicians and nurses, the kind of me first attitude that we have, we must take care of our own first. The fact that the fact that we look at the differences in numbers, Johan, your second slide, or whatever it was, third slide, the fact that we look at the differences in numbers of cases in the US, for example, and cases in South Africa, and we make sort of immediate snap judgments. So, well, of course, Africa's doing better because the population is younger, or et cetera, when really what it is a matter of measurement error. And when you look at the right thing, when you look at things like excess deaths, then all of a sudden this idea that, well, we need to hoard the vaccines for ourselves because Africa's doing just fine by itself, all of a sudden flips when you actually present the data the way that Johan did.
Johan, any follow-up comments on that and sort of the factors that have been exacerbated by COVID in terms of the the disparities between the global north and global south?
Well, I think where we failed is to recognize that this is a global pandemic which has to be managed as a global pandemic. And even within the US, I mean, you have a federal policies, you have state policies, you have mayors making decisions, and the management and planning has been so fragmented, and that's been the whole world over. And really, this is where we should really have put our weight behind the World Health Organization and or a similar organization which might have been created specifically for this purpose, and to have a global and have a public health approach to the whole issue.
Great.
Mark, can I jump in here for a second?
Yes, absolutely.
I totally want to just amplify this. This shouldn't be framed as a national security issue. It shouldn't be. It should be framed exactly the way that Johan framed it, that this is an ethical, moral issue. And as Dr. Tedros said, we're on the brink of a catastrophic moral failure. It is also a national security issue. It is also the truth that until everyone's safe, none of us is safe. So there are multiple reasons to be addressing this as a global issue as opposed to an isolated issue.
Yeah, I completely agree. And I think, unfortunately, or for whatever reason, until people also wake up to the economic, catastrophe that we are also about to experience, if we don't turn around and think about this in a global way, that's where it could possibly have an effect on the North actually realizing that, it's a global pandemic. Everyone's health can affect us, and one person at any country can get on a plane and bring COVID back, even if it's completely gone, which we know it's not going to be. But the economic effects on all of us are so impactful, and that might be the only thing that can help the North to kind of wake up and turn around. I understand the moral obligation that we have to the global health, but that might not put fire under people's, the way, if you think about it, you can actually calculate the cost of not taking care of everyone and not spreading the vaccine and not sharing this with people around the world. And it's an impact to us all. And that, I think that might be something that we could communicate and would be important people could take action for.
Thank you, Melonie, for those comments. Again, very insightful. There's a question from the audience, Felicia Alawuni, and I'm going to address this to Dr. Konney. So it says, I'm a first-generation Nigerian American and would love to contribute to global health. However, I'm concerned about corruption. How do you address sort of the corruption in the healthcare system in your particular country, if there is any? I don't know enough about the Ghanan healthcare system to know, but I guess there's some implication in the question that there's corruption in some countries, and certainly that could be said for Western countries and Eastern countries, Northern and Southern countries. But how do you see this in Ghana, Anna?
Well, yeah, I'm from Ghana. Nigeria is not far from Ghana. We are all English-speaking countries in Ghana as compared to other African countries surrounding us. They are all francophones, and I know Nigerians are more affected by corruption. And in like where I am, I'm not a politician or anyone. I'm just a healthcare professional in the hospital. In the hospital, I don't think there is any corruption or anything that's, I mean, I was not raised in Africa, but most of my life I live in Africa. And I don't nature or I don't sustain that if someone is corrupted in any way. So I don't think in Ghana is as much as corrupted as Nigeria. That's how I see it. And I don't know why the question come here. And can I add to what national our topic on vaccine? in old African proverbs, they're saying that if you want to go fast, you can go alone. But if you want to go far, then we can go together. Meaning, if we are globally affected by the disease, by COVID-19. So I think the globally should be a global picture, not we developed vaccines, so we have priority, and then Africa is not part of us. I think we should look from this old proverb of African proverb, which shows us how wise saying what are the words and how we are wise in that statement that if we want to go far, then we should go together. But if you want to go quickly and then win something, at the end of the day, you rather lose. And I think that will be my conclusion.
That's a great conclusion, and a great way to conclude this sort of little section of this panel with that African proverb. I wanted to, in the last 20 minutes here, so discuss amongst the panel some of the challenges and opportunities in head and neck surgery training and education, the impact on trainees. Dr. Fagan mentioned some of this in his talk, some of the remote learning pros and cons, and any sort of paradigm shifts, things, silver lining, lessons learned for normal times beyond COVID that we may be able to take with us. So Mark, Shrime, any thoughts from Europe, Ireland?
Mark, this is a great question. I'm actually gonna pivot just a tiny bit on this question to looking at paradigm shifts in the world of research, especially in the world of global health research. I'm less involved in the direct education of ENT and head and neck trainees, so that's, I think, why I'm being selfish and pivoting a little bit.
Great.
There is inherent in a lot of global health research, it's sort of either an underpinning or at least whiffs of shadows of vestigial colonialism. And one of the things that this pandemic has forced on us is the fact that we can't travel. The fact that I'm, stuck in Ireland or in the US, and if I have a project that's happening in, you name it, in Malawi, then I am forced to rely on my in-country collaborators, which is just a horrible way of saying things, because that in and of itself sort of surfaces the inherent colonialism I am forced to rely on. But what it has actually shown us, a lot of us, is that, my gosh, like, why weren't we doing this before? Why wasn't this being driven from Malawi or Madagascar? At least I hope one of the silver linings that comes from this is a continued reckoning with how much of global health is health over there, and how much of it really is bringing surgery, bringing ENT, bringing head and neck care to anybody who needs it, wherever they happen to be.
Really appreciate those comments, Mark, about the global research. Melonie, in your role as Vice Chair of Education, not only for training and research, but sort of training in the clinical training, what types of shifts have you seen amongst the residents there in Pittsburgh?
Well, one silver lining thing that came out was I think there were 3 different series of online educational lecture series that many of the residents in the United States, and actually residents from other countries as well, joined in on. And it was a time when patient care was slowing and the residents were kind of not as busy. And there were several lecture series that residents from around the world could be a part of. And so that, I think, is probably going to continue in some way. I know we've all participated in more, just reaching beyond our own local network for education for the residents. Unfortunately, they hadn't seen that for the medical students quite yet. And I think the medical students had a rough way to go this last year with learning how to dissect a cadaver on Zoom or do a head and neck exam on Zoom. That was tough, but I think the residents did get a little benefit out of that. Of course, there's just less cases, so less hands-on. And that was probably difficult, and hopefully they'll be coming out of that.
Thank you so much, Melonie. Johan, with your, you have a fellowship program there that you've had for 12 to 15 years now. How has this been a unique time for your fellows and your resident training there at Cape Town? So what are some of the lessons you've learned that maybe you would take forward from this?
Well, fortunately, our head and neck fellowship has been untouched because our head and neck cases have been going ahead. But our otology has come to a standstill, as has our rhinology. So it's been a real problem for training. And we've had to switch some of our training to temple bone labs. We've been doing cadaver dissections for our rhinology and relying on other forms of training. So it's been a real concern. But I think we've also learned that you can learn far more in the lab than we thought we could. And so some of these teaching tools most certainly will be retained in the future.
Yeah, and you mentioned Johan, the African Head and Neck Tumor Board. What are the future plans for that? I mean, you mentioned the success. Is the plan just to continue that for now? Any other future plans with that? I know that there have been a lot of international societies that have had conjoint sort of tumor boards with the African Head and Neck Society. So just a few comments on that.
With the tumor board has really been exciting. You know, Africa is a huge continent, and for colleagues to get to know each other by meeting once a year, society just wouldn't have grown. So now we meet once a month, and so it's been a wonderful opportunity. It's also been a good way for us to develop an African way of doing things, because we work in a low resource environment, and so I think we are developing a certain culture of how to manage head and neck cancer, which would be different from North America. And it's also managed to put the African Head and Neck Society on the map, because now we have attendees from all around the world attend. And so most certainly that's been a real positive from the whole COVID pandemic, is that we now have the Zoom platforms to work with.
Great. So Dr. Don Weed has a question from the audience. Low resource settings have as a primary resource limitation the number and specialization of healthcare providers. What has the impact of COVID been on the availability of healthcare workers, both in the delivery of care as well as the provision of training to be future providers? Will this impact be one of the longer term impacts of COVID, well beyond any stability achieved once vaccinations are more widespread? Johan, do you want to take that question? You're on mute.
Could you just repeat the question? I've got double sound here.
Low resource settings have as a primary resource limitation the number and specialization of healthcare providers. What has the impact of COVID been on the availability of healthcare workers, both in the delivery of care as well as the provision of training to future providers?
Yeah, well, certainly, it has highlighted the shortages, but we've had to divert a lot of our specialists and the COVID care, because we don't have enough doctors to man our ICUs, and we're also concerned about the immigration, which has been fueled through the visa programs in the US and UK, which is going to reduce our numbers. And then, as we said, we have to vaccinate high risk communities all around the world, preferentially. So before you vaccinate your young people in the US, we should be vaccinating healthcare workers around the world, high risk settings. Because we have lost a lot of doctors, lots of senior academics, and lots of nurses to COVID so during this period.
Excellent comments, Johan. moving on in the last 11 minutes here to our last topic of the hour. Global meetings and global head and neck surgical societies in 2021, the sort of new normal of hybrid meetings, increased or decreased relevance of local or national or international societies, and how must our societies change to meet the needs of global head and neck surgeons. And there will be an hour tomorrow dedicated to this as well. So to continue this discussion tomorrow as well. But here we have Melonie Nance to give us a few thoughts on that, and then we'll have a little bit of discussion.
Thank you. Can you see my screen now?
Yes.
Okay. Thanks, and you're right, there will be a great panel on this tomorrow as well. And just kind of touching on some of the concepts. And I think Dr. Fagan really addressed some of this as well. I think the African Tumor Board is a perfect example of kind of what I'm going to be talking about, and I'm so glad it's going to continue. My only disclosure is that I love traveling around the world and going to meetings. And when some people say they love something so much, they married it. And if you know me, you know my husband also loves going around the world talking about head and neck surgery. But, you know, part of it is because of just the benefits of travel. Looking at this panel, for example, and really, you know, us in the United States, I think especially really need to open our eyes and see that there are so many different scientific, educational perspectives that we can learn from. I think, you know, with the pandemic, we've learned that American exceptionalism is maybe not that, and that the playing field was really evened out when the United States also faltered and experienced the pandemic the way we did. And even though we're now starting to get up with the vaccine, there's still some work that we need to do in terms of how we can help with distributing the vaccine more equitably around the world. And I'm so glad that Dr. Fagan is talking about this. But the benefits of travel, you learn new scientific perspectives, educational paradigm, different ways to educate surgeons, looking at the way patient norms are different. I would love to hear so much more about the African way of doing things that Dr. Fagan talked about. And I think us in the American Head and Neck Society can learn from that and probably take some great pearls from that. And then just cultural exchange. This picture is just a picture of me on my first mission trip, which I know mission trips are kind of the old way of thinking, but I would say that this mission trip was probably, this was started by Dr. Armando Sardi, who is from Cali, Colombia, and he brought a group of doctors to his home country. And over the years, we were able to just basically extend the healthcare that they already had and also educate and work with the medical students, and to the point where now we're actually not needed, and the mission trip is not necessary anymore because their healthcare system has evolved. So maybe, you know, as mission trips go, this was a success. But obviously the paradigm away from just going on a mission and bringing a colonial version of your healthcare to some other culture, that paradigm is moving away. And we're thinking about surgical training. We're thinking about how we can share information and how we can learn from one another, developing fellowships and allowing people to train themselves and train us as well. We've always been, you know, as a head and neck society, inviting experts, both, you know, into the United States from around the world, and then us as members of the Head and Neck Society invited to other places to give talks and participate in local societies, as well as visiting scholars, students, and fellows coming and staying for some amount of time to learn new techniques. Obviously networking and working with, you know, fellowship interviews and jobs. So, I mean, there are so many global societies in head and neck that I can't list them all, and I don't want to leave anyone out. So I didn't make a comprehensive list at all. And everyone this year obviously had to stop what they were doing, which was having these in-person meetings, big conferences, and go virtual. And it was kind of positive because it even the playing field and allowed us to participate in meetings all around the world. But I know we miss being in person. There's so many wonderful things about an in-person conference. The live lectures and learning from experts, but also interacting with your colleagues, learning from colleagues in a conversation on the fly, research collaboration, the opportunity to have interviews and discuss new job opportunities with people who may have not thought of those things, and things come up, sharing innovation and research meetings and cultural exchange. And this is compared to, you know, the online conferences such as the one we're doing now, where you can share the information to a much farther audience, which is a plus. You can archive the information and look at it later if you're in the operating room instead. It's obviously less expensive, which can even the playing field in some ways. And so there are definitely pros and cons. One thing I just wanted to kind of talk about is the difference between one-way and two-way communication in terms of our meetings. You know, in an in-person meeting, everything's kind of going out. I mean, in an online meeting, everything's going out from one source to many, and that's great. And maybe it's less expensive, but then you miss the two-way communication. You miss the interpersonal. You miss the question and answer. It's possible on Zoom, but it's just not the same. So, you know, looking at our societies overall, I mean, we actually are driven by these large in-person meetings, and that's the financial drive for many of our societies. So that's another important consideration. And, you know, I hope that just like the African Tumor Board that Dr. Fagan presented, we will continue to develop a hybrid meeting where possibly we could have an in-person conference with some people or people in a certain region or something can get together, and we could have in-person interaction and talk. And then instead of us all sitting in our homes on Zoom, maybe each small group could communicate with one another through video chat, video lecture series, and possibly having these different small meetings kind of join into a large meeting if we're not able to have one big international meeting right away in the future. And this would allow for information sharing and then also be able to archive that content. So this is my family going to a meeting. And so I just wanted to say that I think what our goal is to really take what we love so much about in-person meetings and also bridge that with the online Zoom platform that has really equaled the playing field.
Great insight, Melonie, in that presentation. I wanted to give Johan and Anna a chance to, in the last, we have 3 minutes left, a chance to comment here in terms of what you guys see as the needs from large national, international societies and meetings to meet the needs of our global surgeons.
Perhaps I can just start by saying that we've had some wonderful opportunities where courses that one normally pays for in the US have been broadcast to members of the African Head and Neck Society for free. And so I would urge big societies and universities and others that run courses to consider using this as a form of surgical outreach or educational outreach, that you do discount these courses to colleagues and trainees from lesser endowed or well-endowed countries around the world.
Anna, any follow-up comments?
Yeah, thanks, Mark. I think we have locally positive impact through, though the COVID has done so much negative impact, but there are some positive impact because we are reaching out to different societies locally in a country through the Zoom meetings and through the virtual platforms, as well as the Africa as a continent and many other societies were reaching to us, especially from US, we had a free participation in India conferences as well. I think last few weeks ago, we had participated at a reduced price as a medical student price in UK on thyroid cancers. So I think the impact for us, we benefited so much through this, though it was challenging, but we were able to reach out, and by doing so, we have we cut off the expenses on traveling and then moving from country to country, and I think that's how the positive impact was felt from our side. Thank you.
Well, with that, Anna, thank you so much for those comments. I do think you bring up a good point about consideration for special rates for some of these meetings for members of societies in developing countries. I think we thank our panelists, Doctors Nance, Fagan, Shrime, and Konney, for such inspiring perspectives here. And this conversation will certainly, this is only the beginning, it will certainly continue with some of the panels throughout the rest of the day today and tomorrow, and also at our upcoming International Head and Neck Society meeting in July. So with that, thank you, Dan, to you and Melonie as the conference co-organizers. Thank you very much.
Mark, thank you. That was truly outstanding. And I want to thank every member of the panel, and especially our international members who took time out of the later parts of your day to be with us. Your perspectives are amazing, but more amazing is the work you do on a daily basis. And we only hope to be more supportive with this organization. So I thank you very, very much.